autopsy images. These are few autopsy images which clearly shows corpus callosum, caevum septum pellucidum, along with the other normal structures of the anterior complex, which will be dealt in detail in the sonoanatomy part. So caevum septum pellucidum is a
you can just show it for our reflection of memory. Yeah, it's a good image.
So actually, here this is the anterior intrahemispheric fissure, which continues as a here continuously we can see the corpus callosum, that is the genu of the corpus callosum, with the two frontal horns of the lateral ventricles on either side of the caevum septum pellucidum. So CSP is a rectangular clear fluid filled space found between the two septal leaflets. And the clear fluid here is actually not CSF, but it is in fact a filtrate of CSF that is transferred from the ventricles through the septal laminae. And this fluid does not communicate either with the subarachnoid space or with the lateral ventricles. So if we draw an arbitrary line that passes through the fornicial columns and along the foramen of Monro, the area behind this line is nothing but the posterior extension of caevum septum pellucidum, and it is named as caevum vergae, whereas the area in front of this line is the caevum septum pellucidum. So by around 37 weeks of gestational age, the CSP starts obliterating posterior-anteriorly, that is starting from caevum vergae towards caevum septum pellucidum. So CSP is bounded anteriorly by the genu of the corpus callosum, superiorly by the body of the corpus callosum, posteriorly by the anterior limb and columns of the fornix, and inferiorly by the anterior commissure as well as the rostrum of the corpus callosum, and laterally by the leaflets of septum pellucidum. So coming to the functional part, as we all think, the septum pellucidum is not just a membrane, but it is an important part of the limbic system, which is involved in emotions, behavior, as well as memory. So this septum pellucidum is composed of both gray and white matter running along the medial walls of the lateral ventricle, and it is lined by ependyma along the ventricular surface, and it contains glial cells, scattered neurons, nerve bundles, and veins that connect to the choroid plexus. The septal nuclei here are thought to be involved in reward processing, emotional regulation, as well as social bonding. Hence, it plays a major role in integrating emotional and memory-related information.
I have a lot of septally abnormal people around me then. Only today I realize why they seem normal on imaging, but okay, thank you for that. Say septum pellucidum and emotion, it seems. No, including me, I agree. You proceed, ma'am.
So now proceeding with the sonoanatomy part, let's begin with the most important structure, that is the anterior complex, which constitutes of the middle caevum septum pellucidum, which is bounded by the septal leaflets in close opposition with the two frontal horns of the lateral ventricles, and it continues anteriorly with the genu of the corpus callosum, the callosal sulcus, which is nothing but the pia covering the outer aspect of the CC, and the fox cerebri abutting the genu of the corpus callosum. So in axial plane, actually, the genu is not clearly visible because of the fact that the beam of incidence is directly parallel to the corpus callosum. Whereas this is a coronal plane, which clearly gives the anterior complex picture with the genu seen very clearly, because the beam here is directly perpendicular to the genu. So we can see the genu clearly along with the two frontal horns of the lateral ventricles with their concavity being faced outwards. So in normal individuals, this gives a goat horn appearance, whereas if there is any reversibility in the concavity or if there is distortion in the shape of the frontal horns, then actually it is an indirect sign of underlying CC anomalies or any other cortical malformations. So as we all know, prosencephalan development occurs in 3 stages, that is the formation, cleavage, and midline development stage. So if the defect occurs in the formation stage, it leads to aprosencephaly or atelencephaly, and if the defect occurs in the cleavage stage, it leads to holoprosencephaly, and if the defect is in midline brain development stage, then it leads to CC anomalies or septal agenesis. Whereas in all these 3 defects, it is associated with either absent CSP or abnormal CSP. So all these international guidelines shown here recommends that CSP is one must structure that should be routinely screened in our basic examination of fetal central nervous system. So as we all know, CSP is present in all three basic fetal brain planes, that is the transventricular, transthalamic, as well as transcerebellar planes. And it is seen in 100% of fetuses and 15% of adults. So it is a normal structure for the fetus, and if it is found postnatally, then it is considered to be an anatomical variant. So CSP becomes visible by around 17 to 18 weeks of gestational age, and the fusion starts occurring by 37 weeks of gestation. So it should always be seen between 18 to 37 weeks, whereas non-visualization of CSP prior to 17 weeks and after 37 weeks is actually considered to be normal. So by this time, we all would have been familiarized with this tabular column, which actually shows the relationship between CSP and CC. So what we see here is in complete agents of corpus callosum, both CC and CSP will be absent, whereas in conditions such as partial agenesis of corpus callosum and CC question.
Take us through one by one. Don't assume we know. We don't know.
Okay, sir. So normally, in normal individuals, both CC and CSP will be normally present. Whereas in case of complete agenesis of corpus callosum, both CC and CSP will be completely absent. Whereas in conditions such as partial agenesis of corpus callosum or corpus callosal dysgenesis, both CC and CSP will be abnormal. Whereas there is one condition which is called septal agenesis, where both CC and CSP will be absent, whereas the CC will be present. So this is indeed the only condition where both CC and CSP will talk different languages. So that is the condition which we are going to deal with today.
So go back. Yeah. So one important point I would like to tell these people is that you should be very familiar and you should take good images to pick up this. Okay, then only you will pick up this, suspect this, and then you'll land up with this diagnosis. Okay, so if you're very perfunctory, callous, careless, then you will think, oh, I have imaged the CSP. And then this will be there and missed, picked up later by your friends. Please proceed.
So now coming to one picture which we often get confused with CSP imaging is a fornix. So the differentiating features here are both will appear in the rectangular box, but CSP will appear completely anechoic, whereas CC will appear as a linear echo inside the rectangular box. Fornix will appear as a linear echo inside the rectangular box, and the plane of the imaging plane of CSP will be slightly cranial to that of the fornix.
Go back. One thing that you should do when you see a CSP and you're thinking maybe CSP or fornix, because sometimes reverberation artifact can confuse you in a thick woman, is that, okay, once you see this, rotate your probe and make it long. You can never make the fornix long, but always the CSP you can bring it long. And that little bit of posterior aspect, what she told us, what? Verge. That if you show it, so if you start making it long, then you can be sure that it is a CSP. This is only where it's a lot of reverberation is there in a thick woman. Please proceed, ma'am. Yes, please.
Yeah.
So the other structure which we get confused with CSP is cavum vergae. As we already saw, is nothing but the posterior extension of CSP. So here the image in the left shows the cavum septum pellucidum, which is located more anteriorly. Whereas the image on the right shows cavum vergae, which is located more posterior and kephala to the CSP imaging plane.
Am I audible? I think this
Yes,
is what
please.
I was saying.
Yeah.
Important point to differentiate between CSP and CV is that CSP, if you slightly make it, more cephalad, you can extend it to a cavum vergae, whereas this is not possible when you see the fornix.
Fornix, correct.
So coming on to CSP biometry, in normal individuals, CSP is rectangular shape in 75% of the conditions and 75% of the individuals, and it is triangular in the remaining 25% of the individuals. So the length of the CSP is directly proportionate to the corpus callosal length. In normal individuals, CSP is longer than wider, which means the length is more than the width. Whereas in conditions associated with short CC, the CSP will also be shorter and wider. Coming to CSP width, which is nothing but the largest distance which is measured on the inner surface of the septum pellucidum. So if we consider in rectangular shaped CSP, it is measured in the midline, whereas in case of triangular shaped CSP, it is measured at the base of the triangle. So the mean width is found to be around 3.4 mm, with the range being in between 2.08 to 4.72 mm. So this is an article which gives a nomogram for normal CSP width. If we see here, the maximum width is seen at around 30 to 32 weeks of gestational age. And after that, it remains constant till 37 weeks. And from 37 weeks onwards, it slowly reduces its size and starts fusing completely. So the other measurement is the CSP ratio, which is nothing but the length to width measurement. Here, the length is measured from the anterior-most point of the CSP to the posterior-most point, whereas the width is measured in the midline irrespective of the shape. So if it is more than 1.5, then it is considered to be normal. And if it is less than 1.5 or less than 5th centile, then it is considered to be abnormal. So now we came to know that CSP is a part of midline brain development, and it acts as a marker to detect abnormalities of the corpus callosum and CNS organization. So a normal anterior complex is always a strong indicator of fetal CNS normality. So a few slides regarding MRI anatomy, because MRI serves as an important tool here to distinguish between isolated septal agenesis with septo-optic dysplasia along with the presence of any other septal, CNS abnormalities, because it creates a great impact in the prognostication as well as counseling part. So these are few T2 weighted MR images showing normal anterior complex in all the three planes, that is axial, coronal, sagittal plane. So here we can clearly see the normally appearing CSP with two frontal horns of the lateral ventricles and a normally appearing gene of the corpus callosum and anterior or frontal interhemispheric fissure. Whereas here in sagittal section, we can clearly see the completely normal corpus callosum along with the normally appearing cavum septum pellucidum. So these are few axial T1 and T2 weighted MR images of optic chiasma. So actually the X-shaped structure which we see here is optic chiasma, whereas the ultrasound imaging part of the optic chiasma will be dealt in detail in the upcoming slides. So coming to abnormalities in CSP.
Was that a fetal MRI? It was very clear.
It's a neonatal MRI.
Neonatal, okay.
So coming to the abnormalities in CSP, abnormal CSP is almost always a manifestation of underlying CNS pathology. So it can manifest either as absent CSP, large or dilated CSP, small or narrower CSP, distorted CSP, or obliterated and collapsed CSP. So now we will be discussing about the differentials of absent CSP. So this is found in conditions such as complete agenesis of corpus callosum, septal agenesis and septo-optic dysplasia, holoprosencephaly, sesencephaly, hydranencephaly, ventriculomegaly, and porencephaly. So coming to septal agenesis, which is actually a rare congenital cerebral developmental anomaly, which is seen very rarely in isolation. So isolated septal agenesis is always a diagnosis of exclusion, because its presence serves as a valuable marker for underlying CNS pathology. So it is defined as either partial or complete absence of the leaflets of septum pellucidum, and its prevalence in the general population is found to be around 2 to 3 in 1 lakh individuals, and it is found to be mostly sporadic in origin. Also, it is thought to occur due to a primary or secondary cause. The primary cause is commonly thought to be a continuum of the prosencephalon malformations, whereas the secondary cause can be due to destructive or barometric lesions that occur in conditions such as severe ventriculomegaly, intracranial hemorrhage, and fetal infections that will ultimately lead to destruction of the septal leaflets.
Barometric. ரொம்ப பயங்கரமான வார்த்தைகளா இருக்கு. அப்படின்னா என்ன? Because of the pressure it ruptures, is
Yeah,
it?
basically,
pressure effect.
basically, tibial ventriculomegaly, it causes secondary destruction of CSP and corpus callosum because of increased pressures, right? This is what.
Cause fenestrations in the septal leaflets, leading to obliteration of the cavum septum pellucidum.
Okay.
So the important components of septal agenesis are absent CSP and septum pellucidum with single fused frontal horn of the lateral ventricle, along with the normal intrahemispheric fissure and normal corpus callosum with cleaved frontal cerebral lobes and normally appearing fornices. So this is our case who is a 25 years old primary gravida in a non-consanguineous marriage who presented to us at 26 weeks, 5 weeks gestational age. And this is our ultrasound image axial plane, which shows that the CSP is not visualized and the septum pellucidum is also absent, along with the single fused frontal horns of the lateral ventricles. And again, this is a coronal plane, which reconfirms the findings that absence of CSP along with the septum pellucidum and a single fused frontal horns of the lateral ventricle. And here we can clearly see the corpus callosum, which is normally located. So these are the sagittal images, which confirms the corpus callosum in its with its normal morphology and a normal pericallosal artery sweep. And this is an axial plane showing the normal presence of optic chiasma within the plane of circle of Willis.
Excellent.
So actually we suggested fetal MRI for this case, but the couple unfortunately didn't turn up.
Actually, for the students, this is a different case, okay, where we just wanted to show the optic chiasma. In the previous case, we could not see the optic structures that well, and we had advised MRI. But as is a scenario, they had not done, and we lost the follow-up. So this is just a real-time clip showing the, making an attempt rather to show the optic chiasma here.
Hold on. It's very nicely seen here. Yeah.
So this is an MRI image of a similar case who presented with isolated septal agenesis, and the MRI was done at 30 weeks of 30 weeks gestational age at a confirmed absent CSP along with mild bilateral ventriculomegaly. And these are few other axial T2 weighted MR images, which again shows septal agenesis along with single fused frontal horn and a normally appearing optic chiasma. So if we prenatally diagnose a case of septal agenesis, only 86% of them turn to be truly isolated postnatally, whereas the remaining 14% are found to have additional findings. And among these, the overall risk for septo-optic dysplasia is found to be around 19 to 20%, whereas current literature shows that the rate of SOD association postnatally ranges from 18% to 67%. Also,
Okay, is it, what should we quote now? 19 to 20, or you give a very broad range?
I think the two important figures here are once we have diagnosed septal agenesis prenatally, 14% of these cases, even if it is isolated prenatally,
Yeah.
14% of cases in postnatal will have additional findings.
Okay.
And one of the most important conditions which is diagnosed after birth is septo-optic dysplasia. And also this figure is, if it is truly isolated, there is no septo-optic dysplasia, there are no additional abnormalities. In long-term follow-up, 7% of these neonates and children are seen to have neurological
Some
disability.
degree of neuro. Okay.
Neurological
So,
disability.
yeah, I think
So
it's a very important
7%.
slide.
Yeah.
Clip it. We will put a counseling statement.
So this is a retrospective study done on isolated septal agenesis cases by Elizabeth et al. And it showed diversity in the postnatal outcome, starting from gross developmental delay to abnormal hearing and visual disturbances, seizure disorders, and variable degrees of intellectual disability as well.
So actually, this is one latest study in 2022 with the largest series of a septal agenesis, which they were successfully able to follow up in the postnatal series. And these are the various outcomes, abnormal outcomes that have been associated in these cases, which includes most common abnormalities seen in these children were language delay, gross motor and fine motor issues. Some of this required therapy. And then there were minor issues such as reading, hearing, vision. And occasionally they are met with seizures, postnatal development of ventriculomegaly, and overall association with genetic abnormalities have been very extremely rare. So I think this is a very useful table which
Yeah,
shows, the
yeah,
outcomes.
correct. It also, if we see carefully, the pattern is similar to what we counsel for isolated ACC, no? The defect spectrum, speech predominantly, some degree of motor, and then seizures. So it's very important. Yeah. So all these put together, 7%, is it, Sineesh?
Yes,
Yes, sir.
yes, in truly isolated
Yeah.
cases.
So if we do everything postnatally, you find it truly isolated or not SOD, then there is a
Yes,
residual risk of 7% for any of these things
right.
in variable severity or always severe.
Variable
Very
severity.
All right.
So, Harris et al. In the year 2018 published a study on the use of maternal serum estriol levels as a method to predict fetal endocrine anomalies, but this possibility has never been evaluated by other investigators because of the fact that normal estriol levels cannot exclude septo-optic dysplasia. So, the prediction of postnatal hypopituitarism is theoretically possible using fetal T1 weighted MRI by the presence of anterior pituitary hypoplasia and undescended posterior pituitary gland or an absent pituitary stalk. So, the prenatal distinction of septal agenesis with septo-optic dysplasia is very difficult and quite challenging one.
Do you have the details with regards to the Harrods paper? Because I'm interested to know if there is a hypo levels of estriol, and as we know, estriol is not normally formed by the mother. Will that be predictive of an abnormal outcome?
So I think these are some of the initial studies which show that there might be some association with low level of these anterior pituitary hormones with septoptic dysplasia. But as Smitha has told, there are two issues. One, large-scale prenatal validation is absent. Large-scale prenatal validation is absent. Another important point is normal anterior pituitary hormone levels do not exclude septo-optic dysplasia, because as we will see in a later slide, it is not necessary to have an anterior pituitary issue in all cases of septo-optic dysplasia. So this is a very sensitive method to distinguish between the two conditions. And from what all we researched, we found that a very well done fetal MRI is a strategy which can help us to differentiate, the septal agenesis and septo-optic dysplasia, because at least they would show either the anterior pituitary hyperplasias or the optic chiasma and optic tract issues.
All right. So mainly image based.
Mainly image based.
Okay. Perhaps Smitha can do a journal club, present that journal later.
Okay, sir.
Thanks.
So, septal agenesis can be associated with septo-optic dysplasia, CC and fornicial anomalies, holoprosencephaly, season-cephaly, and malformations of cortical development. So, coming to the primary differentials for septal agenesis, which is nothing but septo-optic dysplasia, which is otherwise known as de Morsier syndrome, which is diagnosed definitively if it has 2 out of these 3 features, that is optic nerve or optic chiasma hyperplasia, pituitary hyperplasia, or septal agenesis. So only 30% of the fetuses are found to have all these 3 features. So among these diagnosed cases, 60% are found to have visual disturbances, 62 to 80% are found to have partial pituitary dysfunction. Most common is a growth hormone deficiency, and 40% are found to have developmental delay. So the prenatal diagnosis has a poor specificity, with only 20% of the prenatally diagnosed septo-optic dysplasia cases turning to be truly turning to have SODs postnatally. So coming to the etiology part, as we all know, SOD occurs due to an early forebrain developmental abnormality, and it is a phenotypically variable disorder with an incidence of 1 in 10,000 live births. And it is found in high association with young maternal age and maternal habits such as smoking, alcohol and substance abuse, valproate toxicity, and also certain environmental factors associated with low socioeconomic status and intrauterine vascular disruptive events all together play a major role in the causation of septo-optic dysplasia. Also, this condition is found to have a genetic etiology, which is thought to be caused by mutations in HSX1 and SOX2 genes, whereas a genetic diagnosis can be currently made only in less than 1% of the patients, which indirectly means that in majority of the cases, the etiology still remains unclear. So a few words regarding the molecular and genetic basics behind septo-optic dysplasia. As we saw, it occurs due to early forebrain developmental abnormality, which takes place at around 4 to 6 weeks of gestational age, which is a critical period of morphogenesis for the anterior neural plate. So improved understanding of this development of forebrain and pituitary gland, along with the identification of transcription factors important in this process, has led to the discovery of genes which when mutated causes septo-optic dysplasia. So the two most common genes involved here are HSX1 and SOX2 genes, where HSX1 is a homeobox gene, which means these are a group of genes that are responsible for the morphogenesis phase. So HSX1 acts as a transcription repressor gene here, and it can manifest either as homozygous or heterozygous pathogenic mutation. If it has homozygous mutation, then it manifests as a more severe form of autosomal recessive disorder. When it has heterozygous mutations in it, then it is found to manifest with a milder state of autosomal dominant disorder with varying degrees of expressivity and variable penetrance. SOX2 mutations are found to have severe bilateral eye abnormalities, CC defects, and anterior pituitary hyperplasia. So, establishing the genotype not only furthers our understanding of the etiology, but also aids patient management, enabling accurate genetic counseling and early diagnosis. So coming to the recurrence part, since most of the septo-optic dysplasia cases are sporadic in origin, the recurrence risk is very low, that is less than 1% in the absence of family history. Whereas in case of consanguineous families, the likelihood of autosomal recessive inheritance is slightly higher, to say for at about 25%, even if there are no identifiable genetic mutations among the family members.
Kana 1% and 25% slightly higher சொல்றீங்க?
I think
ரொம்ப அதிகம்.
within consanguineous families, if there are cases of septo-optic dysplasia, then in such families, the recurrence is on the higher side, even if no genetic mutations identified.
Yeah.
But as a whole, the association with genetic abnormalities and recurrence is less than 1%.
All.
Similarly, SOX2 mutations are also de novo in origin with a very low risk of recurrence. So, the variable penetrance and phenotypes associated with dominant HSX1 mutations makes the genetic counseling part difficult and quite challenging one. So, the multifaceted interaction between these transcriptional factors and the environment is also likely to play a role in significant variability in the phenotype and penetrance associated with septo-optic dysplasia. So now coming to the imaging part of optic asthma. Actually, basically, optic asthma is the area of decussating fibers. That is, the medial fibers of the optic nerve cross and continue towards the contralateral optic tract, whereas the lateral fibers of the optic nerve remain uncrossed and continues towards the ipsilateral optic tract. So this middle area of decussating fibers constitutes optic chiasma, and this explains the X morphology of the structure. So from our basic axial plane, we should rotate the transducer to obtain the anterior orbit and the cerebral peduncles. And here we can clearly see the optic chiasma just above the base of the skull and anterior to the cerebral peduncles. And if we switch on the color Doppler, it is clearly seen within the plane of circle of Willis. So again, this is the image which we already saw. So this is a coronal image. Actually, this is the ideal plane to image optic chiasma, where it is seen as a midline structure between the bony skull and cerebral hemispheres. And again, if we put on the color, we can see the pulsating internal carotids on either side of this optic chiasma. So this is a video clip, coronal video clip, which clearly shows the optic chiasma in the midline. So here we can
nice.
clearly see.
Yeah, very nice.
So the pulsating internal carotids on either side of the normally appearing optic chiasma.
Hold on. So we need thalami, we need LS, and so I'm thinking where we should freeze the image. And then we need the internal carotids to sort of go up, like it's cupping in between. Okay. So all these are required. Okay, excellent.
So these are few 2D transabdominal ultrasound images showing the measurement of normal optic chiasma width. So the image, the left image shows the measurement of the decussation width, that is the middle part. So this middle image shows the measurement of the optic nerve width, which lies anterior to the middle, that is the decussation part. And the image on the right shows the measurement of the optic tract width. So this is an article which gives a normal reference range for the optic chiasma width as well as optic nerve and optic tract width.
Can you go back to the previous slide? I just wanted to see the optic tract. Can you zoom on that? Yeah, see. Okay.
The posterior extension from the middle part, sir.
So they simply appear. Okay, I used to mistake that as a bone, and only this part is valid. Okay. All right.
So this is a case of septo-optic dysplasia where an axial and coronal plane we can clearly see the septal agencies along with the single fused frontal horns, whereas this is a coronal transcaudate plane which again shows the hypoplastic optic chiasma. And these are few T1 weighted MRI images suggesting septo-optic dysplasia. Here, the optic chiasma is hypoplastic along with the absent septum pellucidum and CSP with single fused frontal horns of the lateral ventricles.
Yeah. Can you go back to the previous slide? Okay, so again they have the thalami, LS, and here you should have got a gray tissue like this, but they didn't get, isn't it?
Yes.
Yes.
Okay, so we need to confirm it in two planes. So this is the expected image in a abnormal case. All right, thank you.
So coming to the imaging differentials of septal agenesis. So the closest differential would be lobar holoprosencephaly. So the commonest points between these two will be absent septum pellucidum and absent CSP along with single frontal horn. Whereas now we have to apply the basics of embryology. So as we discussed earlier, in lobar holoprosencephaly, the defect occurs in the cleavage stage. So what happens here is there will be normally cleaved occipital and parietal lobes of the cerebrum, whereas the frontal lobe will be uncleaved, right? So there will be absent frontal intrahemispheric fissure and absent joint of the corpus callosum with uncleaved frontal cerebral lobes and fused fornices. Whereas coming to the defect in septal agenesis, which occurs due to a midline brain developmental anomaly, here the cleavage part is developed normally. So the other conditions which are associated with lobar holoprosencephaly, which we saw here, will be normal here. There will be a normally appearing intrahemispheric fissure with normal corpus callosum and cleaved frontal lobes of the cerebrum with two fornices appearing normally. So these are the major differentiating features for these two conditions. And again, these are few T1 weighted MRI images of lobar holoprosencephaly case, which again shows the presence of single fused frontal horn along with the deficient anterior part of the corpus callosum. So the next closest association will be seasoncephaly, actually, which is nothing but a congenital neuronal migrational disorder characterized by a cleft that is lined by gray matter heterotropia and extends from the outer cerebral surface to the lateral ventricles. So it is found to be in 75% of cases of schizencephaly, it is found that septal agenesis is present. So it has high association with septal agenesis. Whereas the other condition is middle interhemispheric variant, where the anterior, that is the frontal and occipital lobes will be normally cleaved, whereas the middle part, the parietal lobe will be uncleaved, associated with septal agenesis and uncleaved body of the lateral ventricles along with the deficient body of the corpus callosum. And these are a few MRI images of schizencephaly cases, which clearly shows a cleft that extends from the outer cortical surface to the inner ventricle, and it is associated with septal agenesis. And these are few images, MR images of scintillencephaly case. Again, we can clearly see the uncleaved middle part, that is body of the lateral ventricles, along with the deficient body of the corpus callosum. Here, the anterior part as well as the posterior part is well developed, whereas the middle part is deficient.
There will be fusion in the parietal cortex.
Yes.
Yes.
For us, that's you initially showed a sweep, coronal sweep, no?
Yes.
So that you'll be able to show clearly. Yeah.
So coming to the practical implications of septal agenesis, once we diagnose absent CSP in all the basic planes, then we should proceed with a detailed neurosonogram and fetal MRI with technical expertise. Whereas genetic testing by amniocentesis with CMA and WES can be done only in selected cases because large validated data is not available to support this testing. Whereas the key prognostic parameters depends on the additional associated ultrasound abnormalities. So it is always challenging prenatally to distinguish between isolated septal agenesis with septo-optic dysplasia. Whereas the presence of these conditions per se is not a contraindication for the routine term delivery. So after delivery, there must be a postnatal follow-up with multidisciplinary team approach, that is with MRI, endocrinological studies, and neurodevelopmental screening. So to summarize, isolated absent CSP is seen in conditions such as septal agenesis and septo-optic dysplasia, whereas in complex forms, it is associated with corpus callosal agenesis, holoprosencephaly, schizencephaly, and severe ventriculomegaly. So true distinction of isolated septal agenesis is possible only postnatally, whereas in conditions such as CC agenesis, along with septal agenesis, the other prominent features such as bilateral colpocephaly, non-visualization of CC in multiplanar imaging, all will help in making the diagnosis easier. Coming to SOD, as we already discussed, it should have any 2 out of these 3 features. Whereas what happens in severe ventriculomegaly is the increased pressure within the ventricles may cause penetrations in the septum pellucidum, leading to obliteration of the cavum septum pellucidum. Coming to holoprosencephaly, here we are very much concerned about the last 2 variants, that is the lobar and middle interhemispheric variant, because the alobar and semilobar variant would be diagnosed quite easily. So this other 2 variants would be the differentials for septal agenesis and with a variable non-fusion of forebrain lobes and variable CC and fornicial abnormalities. And the last one is schizencephaly, which is nothing but a cortical defect that extends to the ventricles, and septal agenesis is seen in around 2/3 of the schizencephaly cases. So coming to the prognosis part, by this discussion, we came to an understanding that the final findings are not revealed in our routine prenatal ultrasound examination. So in general, if there are associated anomalies, then it is considered to have a poor prognosis, and the prognosis depends on the severity of the associated condition. Whereas in case of isolated septal agenesis, the prognosis is considered to be favorable to some extent, provided the condition is truly isolated postnatally. So the take-home message here is, whenever isolated septal agenesis is identified, it warrants a detailed fetal neurosonogram with a fetal MRI done by a technical expert. And the option of invasive testing using CMA or WES should also be considered in selective cases. Whereas in apparently proven isolated septal agenesis cases, the prognosis is favorable, but even then, the 7% risk of neurological disabilities should be kept in mind, which will have a great impact in prognostication as well as the counseling part. So, however, an additional anomaly is detected after birth in around 14% of cases. And among this, there is a SOD association in around 20 to 25% of the cases, which has a negative impact on the clinical outcome, thus making the prognostication and counseling part to be a challenging one. So, postnatal multidisciplinary team follow-up is a must to arrive at a final diagnosis and to individualize the management accordingly. Thank you all.
எல்லாம் விசில்லாம் போடுறாங்கப்பா. Excellent. So we have to add septal agenesis to our list of CNS anomalies where we have the ethical dilemma. We know that when we do a proper examination and find otherwise the brain is normal, many of them will do well, but some of them will not do well. And how do we put it across to the parents? And most importantly, whether the parents will understand the numbers correctly or not. Ultimately, if we make them understand, for example, persistent mild ventriculomegaly, CC agenesis, partial agenesis, okay, and what else? Blake's spouses, that should be easy. Then this septal agenesis. Solita. So these are some of the situations where it's really difficult to counsel. Okay. So what happened to this patient, Seneesh? How did you counsel?
So the first case that she had put.
Yeah.
So I think these many figures were not available, during that time. Though these researchers all have come, a little later than we had this case. So we, in the counseling part, we told them that if it's truly isolated, if there are no additional findings in the follow-up and postnatally, outcome is expected to be normal. That is, a neurodevelopment is expected to be at par with other children. But truly, whether there are any additional findings or not, we would be able to know only after birth with proper endocrinological and MRI studies. So that time also fetal MRI expertise was not that much available.
Yeah.
So in recent years, I think the technical expertise, many radiologists who have turned to fetal medicine, they're also now doing good fetal MRI.
Okay.
So now these days, all these cases we are immediately channelizing to fetal MRI for the final prognostication.
So we used to quote once we have septal agenesis and the neurosonography is absolutely clean otherwise, then we used to quote a 25% chance it will be 1 out of 4 will be SOD and we can't tell prenatally. That used to be our counseling. Maybe we can now slightly reduce to 1 out of 5, 20%. But otherwise fetal MRI will play a role, and if we can image the relevant structures, optic chiasma, complex, pituitary, confidently, then perhaps that risk is lower, isn't it?
Right.
So there are some questions, Smitha and Seneesh, if you want, can take. All questions are from Dhaval only. Akila madam has told excellent presentation, so keep it up. Dhaval is asking how to differentiate optic tract and nerve in the chiasma, and how and what point we have to measure these two structures. Welcome, Amuda.
This image? Can we show this image?
Which one?
The
MRI.
The MRI, this is the one. Differentiating should be easy, no? Anteriorly will be the
Optic nerve, sir.
oh.
So the posterior extension of this middle part is nothing but the optic tract. So the middle decussating area is the optic chiasma width, which we see here.
Yeah. So I find it particularly difficult to the tract path, the posterior continuation to, reproduce consistently. I am able to do the middle decussating part. Optic nerve, we can actually go behind the eye and take, that is easy. But the optic tract part is difficult in ultrasound to show consistently. Maybe
Sir, optic tract is something which is continues into the temporal lobe. So it's a very small tract which is there in the system. So you may not be able to see it on the ultrasound as it's.
Yeah, so thank you, Major. They seem to have shown something here. We need to maybe you can combine this also in your journal club, and we'll see whether they claim it reproducible or they say at the end, this is what we think, but we are not sure. We have to see that also.
Yes.
Okay, so very nice presentation, Seneesh and Smitha. Thank you very much. Some wonderful points we learned today, and hopefully we'll do more such presentations.
Thank you, sir.
Mani, hi Mani.
Hi, madam.
One small comment. Just asking a question, probably not a comment. So when we say in completely isolated cases, which we can diagnose only postnatally, of course, the incidence of developmental issues is about 7%. But that 7% is actually same as in general population, isn't it?
True, madam, that if we go by ventriculomegaly,
Mild ventriculomegaly, huh?
there also we say it is around 7%.
So the thing is, when you say that, say if you want to round it up around to maybe, it becomes like 1 in 10 almost, isn't it?
Yes.
So when you say that, how the parents take it, that has always been my difficulty in counseling.
Correct.
1 in 10 is, if you see 10 children, one among them is challenged in some way, among us also, no? Mani.
Our problem is more severe, madam.
I know. So,
my God.
So are we not, it is so difficult to make them understand that 7% is same as general population, because they expect their child to be perfect.
True.
So the moment you say it is 7%, actually it is taken in some other way from their angle. And that is my biggest problem. And
yeah, absolutely correct.
Almost all of them go for termination. I don't know how. Sometimes ethically, I get very worried, because we are becoming experts in neurosonography, and we are picking these, and then so many cases are going for termination also. Mani, that is one small point that I had to say.
True, madam, absolutely true. I always tell here that you would be thinking, here means to the fellows, you would be thinking that it's a very minor issue, but the patient will be imagining a monster.
Yes.
Inside the tongue, and they want it out immediately.
Yes.
It's difficult. Seneesh, any thoughts on how to approach the counseling part?
It is difficult, as we were discussing, in these isolated lesions like septal agenesis or say Blake pouch cyst. It is, as Akila madam was telling, it is very difficult to give the true picture. And from the patient's perspective, they take it in a completely different way. Everybody wants to have their child as,
Textbook.
The champion for in chess and other things. So these issues, they do take it in a different way. But at the same time, I'm a little worried about the medical legal environment and the litigations possibly which can come if such a child is born with a very severe neuro disability after birth. So I think we should not be prejudiced in our counseling. Whatever fact we have, whatever latest research we have, those figures should be communicated to the patient, and in a empathetic manner, and in a non-directive fashion. Let them decide what to do.
Yes.
So that is our approach here.
No, completely agree, Seneesh. I completely agree. You have to tell them that.
Yes.
The only thing is you have to make them understand that it is something which is seen in general also. We shouldn't put it in such a way that your baby has a much higher risk than others. That's what I'm trying to say. So that is one thing. One more small comment, Mani. Usually our trainees, when they get mid-sagittal section, they tend to think that what is underneath the corpus callosum is cavum septum pellucidum.
Yeah,
That is one small caveat. I wanted to bring it up because many trainees are here. They think that that is CSP. Actually, in absence of septum also, septal agenesis also, you will see this, isn't it? That is actually the
true,
CSF in the communicating frontal horns. Small
true,
point for
true,
trainees.
true. Yeah, it's a very important point. Even in narrow CSP, filled in CSP or obliterated CSP, you have to be absolutely in the true mid-sag, which will be guided by the presence of parks. Then only you should comment on CSP in the SAG view. Yes, madam.
Yes, that's a small point because it is common mistake. It's a communicating CSF, isn't it, Mani?
Correct.
Yeah. Okay, thank you so
Hello.
much.
Hello.
Yes, Dhaval.
Good morning, sir. Sometimes what happen, the irregular shape of the CSP, like not a full-fledged rectangular, but some square shape, some transverse position of the CSP, in spite of having a normal length and width. So in these cases, we should advise the amniocentesis to rule out the DiGeorge syndrome because the CSP, abnormal CSP shape associated with the DiGeorge syndrome. Uh,
Yeah, whenever we think of constellation syndrome, see
mhm.
what is more commonly associated with the syndrome. So, if you're thinking DiGeorge, I would go and check the heart, thymus, palate. If they are not there, then the very rare association with, not a very frequent association, we need not worry about that. That will be there all the time. No,
Okay,
that's
sir.
the main reason for all these who's being reported. Anyway, there are two important questions. One is what is the counseling if it's partial septal agenesis, and is it similar to septal agenesis? And second is role of CSP ratio. Partial septal agenesis, I think Ravinder is referring to situations where there are fenestrations in the cavum septum pellucidum, especially in the posterior half. If you are shining the ultrasound beam perpendicular to the septum, and you may miss it if it is parallel. So, for example, TV coronal plane, you may miss it, but in TA axial plane, it will be seen pretty clearly. I think Amuda has direct experience with 2 or 3 cases which she has discussed before. But before that, Seneesh, do you want to answer that question?
Well, partial septal agenesis is a very difficult diagnosis prenatally.
Possible theoretically.
And yeah, and it's the general line of counseling is same. Look for additional CNS abnormalities. Look for the CC, look for other ventriculomegalies there. In general, the detailed neurosonogram, look for any additional findings. And the counseling would be almost based on the same line. There are no distinctive figures available
Correct.
which differentiate the counseling for partial versus complete agenesis of septum pellucidum. So we also researched on this and we could not find any difference between the two conditions with respect to the counseling.
So for me, partial septal agenesis or septal fenestrations. And if you have clearly made out septum, and I tend to equate it with the other entity which is also being asked in the question, that is the filled in CSP. So in both conditions, the CSP is formed. And then there are perforations in the septum, and which we know can happen after it is formed. So if rest of the brain is clean, I tend to reassure in both this perforation issues and in filled in or echogenic CSP. Septated CSP, though, madam, we can leave it. It is not even worth mentioning. And then role of CSP ratio. Smitha?
So actually,
It was popularized by Ravi Choi, but I don't think anybody else has taken it seriously.
it is considered abnormal if the width is less than 5th centile. That is, the ratio is less than 5th centile, which is commonly seen in conditions such as partial agents of corpus callosum. Mostly, subjectively, we can assess the condition of CSP. But if we want to give a correct measurement, then through CSP ratio, we can calculate and give the final findings.
Okay, so what we follow here is we take the CSP as a separate image as part of our standard protocol. And if there is anything to indicate that it is not the usual CSP in all its glory, then a TV assessment of the CC will be done. And if the CC is normal, then that change in shape or width or narrow, everything is out of the window. Then we don't do anything. When it is extremely broad, then it's called a CSP cyst. Then we say we need to follow at 24 weeks and 28 weeks to see what is happening. All right. All right. So thank you all. Wonderful presentation from Seneesh team. Others also try and present something, but this has set very high standards. No, yes. Our people were nicely enjoying some low-key presentation, but you have put it up in a different orbit, Smitha. Congratulations, and at the same time, you have incurred the wrath of our fellows. They're all
means a lot, sir.
Means a lot. Sorry. Thank you all. See you Monday. Okay. Bye.
Bye, sir.